to the 5th Annual Clinical Research Open House. This year, the Office of the Clinical and Translational Research and the Clinical Research Institute will highlight research work supervised under two of its programs, the Fellowship and Residency Research Program, known as FRRP, and the Medical Research Volunteer Program, known as the MRVP. We commenced our program today with a successful poster session where judges rotated and evaluated posters prepared by graduating residents under the FRRP program and posters prepared by students under the MRVP. Later today, we will have another poster session, and at the end of our program, we will announce the 5 best posters. Before we start the oral presentations prepared by the graduating FRRP residents, I would like to open the floor for the Associate Dean of Clinical and Translational Research and Director of Abu Haidar Neuroscience Institute, Dr. Samia Houri.
Thank you. This is a very exciting day. I'm very, very pleased with the turnout, with the quality of the posters that I see. And I think the Biomedical Research Day is becoming what I really envisioned it to become. This is a time for all of us to see what everybody's doing and to experience the breadth and the depth of research that is ongoing at the AUBMC. I want to thank the CRI, Dr. Elial for his leadership, and especially Dr. Hani Tamim for his efforts. Dr. I'm blocking on your name? Bilal, sorry. Dr. Bilal Kafarani for his leadership of the MRVP program, and also Pamela for her efforts for this program, and all the members of the CRI. Thank you very much, and I hope you enjoy the day.
Thank you, Dr. Houri. And now I would like to welcome the Director of the FRRP program. He's also the co-director of the MRVP, and he's the Director of the BSU unit, Dr. Hani Tamim.
Okay, thank you very much. It's a pleasure to be here today. I have a few slides. I'm not going to talk a lot. I'm just going to present a few slides about the FRRP. So basically, it's a required component for the residency program at the Faculty of Medicine at the AUBMC. It is now under the CRI Clinical Research Institute, directed by Dr. Elial. And each year, all first-year categorical residents are required to carry out one research project throughout the residency program. So the objectives are many, and the program was developed to serve the residents and the fellows, the faculty members at the AUBMC, as well as the institution at large. So the residents, throughout the involvement in the research program or the FRRP, they acquire the necessary skills for conducting research, get acquainted with the IRB process and the application and the approval and so on, and how to publish in peer-reviewed journals. The advisors, of course, they get support for conducting their research, and the publication is another advantage. And at the institution, the cross-departmental collaboration, the number of ongoing research, and the establishment of a culture of research among the residents, which is happening nowadays. So the key players, the committee members, and each clinical department has one or sometimes more than one representative in the FRRP committee. And in each department as well, we have multiple faculty members who serve on the departmental FRRP committee. The advisors, we have more than 80 advisors who are supervising residents now, and overall it's more than 150 attending supervised residents on their research projects. So far, we have 454 residents who have already joined the FRRP. Since 2011, when we established the program under the internal medicine, Dr. Fouad Ziedi's support was major to establish this program. We have so far 194 residents who graduated with their FRRP projects, and currently we have 267 residents who are taking part of the program. And this shows the number as we speak. So, in terms of publications, out of the 194 residents who finished the research projects, we have 28% or 54 papers that were published out of the work that has been done under FRRP. The remaining papers or projects we are working on, and we are helping the advisors and the residents to get as many as possible published in peer-reviewed journals. FRRP, its Fellowship and Residency Research Program, since we started, it was the residents only, and every year we talked about involving and including the fellows in the program. This year, in 2017, the FRRP, or actually in 2018, a pilot phase was established for including clinical fellows. And mainly pediatric fellows, 5 fellows are part of the program now under their fellowship program. And accordingly, next year, all fellows in the institution hopefully will be part of this program as well. Another major achievement that we did in the past year was the portal. So now we have a portal that accommodates submission of the documents, whether it is the questionnaire or the proposal or the evaluations and so on. We can monitor the progress of the residents throughout the portal, and we can export reports and follow up on the residents regarding their work. Finally, I would like to acknowledge a few people who have been supporting this program, mainly Dr. Mohammed Saif, who believed in us and gave us all the support to start this program. Dr. Samia Khouri for her unconditional support as well throughout the past years. Dr. Ali Tahir, of course, who founded the program, we founded the program together. Dr. Fouad Ziedi, because the program started in the internal medicine. Dr. Eli Aal, who is directing the CRI, where the FRRP is hosted now. Of course, throughout the past 6 years, we have had the privilege of working with different administrators or coordinators. Zaina Ai, Sarah Khamsa, and now Pamela Ali Khalil are working with the residents. And finally, the committee members who we keep on bugging them about the deadlines and follow up with the residents and so on. The advisors, of course, and finally the residents. So this is the contact information. We have special thanks to all the jury members who will be evaluating the oral presentations as well as the posters. And thank you very much, and I hope this will be a successful event as well. Thanks.
Thank you, Dr. Tamim. Now we will start with the first oral presentation session, where 7 residents, each representing a different department, will present his or her research work. Now this year, at the end of every presentation, the jury members and the audience will both be asked to evaluate the presentations. And at the end of our program, we will announce the 3 best presentations. So we are going to start with the first department, anesthesiology, and representing anesthesiology is Dr. Ayin Tukhtarian.
Hello, my name is Aline. I will be presenting a project conducted in the Department of Anesthesiology about intraoperative ventilatory management and post-operative pulmonary complications. So to start with, I wanted to show you this picture of the iron lung, the first breathing machine ever, which was invented in 1928, where patients were put inside the air chamber and it used negative pressure to draw air into the lungs of the patients, mimicking a normal physiology of the lungs. Then we improved, moving on to ventilators versus respirators during the World War II in 1950s, when pilot fighters they used ventilators with positive pressure to breathe in oxygen at high altitudes. This was very useful during the polio epidemic in the 1950s to help patients breathe. We moved a long way. I want to start this way to say that we really have come a long way since the invention of respirators. However, I think we still have a long way to go. So in the last decade, the way we ventilate patients in the intensive care unit has really changed. There are many RCTs suggesting that protective pulmonary measures have better outcomes regarding pulmonary complications using lower tidal volume, pressures that are reflective of the alveolar pressure rather than the traditional peak airway pressures, and the tidal volume relative to the ideal body weight would be helpful in achieving better outcomes. But has this translated completely into surgery towards patients who are coming in with normal lungs, being ventilated for a couple of hours during surgery, and is it applicable? Well, there is not enough science to support whether we should use the same settings we use with acute lung injury, and that is why we are doing this study. Of course, post-operative pulmonary complications still are have a major effect on patients post-op, and they have an effect on morbidity, mortality, and length of hospital stay. So we started this study, and our main aim was to have particular focus on the mode of ventilation of patients coming in for surgery at the American University of Beirut under general anesthesia. We focus on the tidal volume per body weight and the PEEP settings to identify subsequent post-operative pulmonary complications. So the inclusion criteria, as I said, included patients under general anesthesia, adults with an ASA score between 1 and 2 who were able to give consent. We excluded everyone who had to be admitted to ICU because of surgical complications, and the patients were followed up at 24 hours and 1 week post-op to screen for post-operative pulmonary complications. Here is the data collection sheet regarding the patient characteristics, their age, weight, height, BMI, etc., history of pulmonary disease. Here is the characteristics of the surgical procedure, because we know that laparoscopic surgery would have a different effect on the lungs of a patient than lower abdominal or gynecologic surgery. The characteristics of the anesthesiologist who is putting the settings on the ventilator, his age, level of seniority, the mode of ventilation he uses, the duration of surgery, the peak airway pressures, alveolar pressures, plateau pressures, whether he got any transfusion, whether they got any neuromuscular reversal at the end of the surgery, everything that might be a risk factor to develop post-operative pulmonary complications. Here are the results. The average age of patients collected was 43, with a BMI of 28. 22% of these patients had positive history of pulmonary disease to start with, and 11% had cardiovascular disease. This is the distribution of the surgeries done, whether they are laparoscopic, open, orthopedic, ENT, etc. So only 5% of the surgeries were deemed emergent surgeries, the others were elective, and 90% of the surgeries had a duration less than 3 hours. Keeping in mind that as the duration of surgery increases, the rate of post-op complications will increase. And the most commonly used mode of ventilation by far was pressure-controlled ventilation, volume guaranteed. Majority of patients received a PEEP of 5 and an FiO2 of 40%, and all the patients had reversal of neuromuscular blockade at the end of the surgery. So the peak alveolar pressures, the mean peak alveolar pressures was 20, mean airway pressures was 10, tidal volume to actual body weight was almost 7, and tidal volume to ideal body weight was 8. We can say that these are relatively low numbers regarding people with healthy, usually normal lungs, not acute lung injury. The rate of post-operative pulmonary complications was found to be 11% at 24 hours and 1.8% a week after surgery. To note that all the complications were minor, there were no major complications. To compare this with the literature, in a cohort study of 1,230,000 patients almost, the rate of post-op pulmonary complications was 13%. Our rate was slightly lower, and these complications included pneumonia, respiratory failure, bronchospasm, etc. And these authors concluded that 1 out of 8 surgical patients had a post-op pulmonary complication. To conclude, this is still an ongoing study at the UNC. Our ultimate goal is to develop a large database of all the patients undergoing general anesthesia in our operating rooms. And of course, the post-operative pulmonary complications was quite low. This may be attributed to protective ventilatory measures applied by the attending anesthesiologists and residents. However, future studies are needed to further confirm the correlation with targeted outcomes. Thank you.
Thank you, Dr. Tukharia. So now I will ask the jury to follow the instructions that were handed to them. The paper that was handed to you, follow the instructions and the numbers that were handed to you. As for the audience, we invite you to evaluate Dr. Aline Tukhtarian's presentation. We ask you to grab your phone, follow the instructions, go to www.menti.com and enter the code 299673 to vote. So once we all enter the presentation number, which is presentation number 1, Aline Tukhtarian was presentation number 1. The code is 299673. The code is 299673 for the audience. So when you first enter the code, it will ask you to enter the presentation number. Put number 1 and click submit, and then wait. Wait until all the people in the audience have submitted number 1.
The second PowerPoint.
Technical difficulties with just for the first round, and then we will be okay. The audience is involved because they are the voice of their friends, the voice of the CRI, and we want their input. So we will take a percentage.
You said it, friends.
and friends and family. It will be a small percentage, but it will make a difference. So I see that 51 people from the audience have submitted a number 1, and now get ready to evaluate. So these are the questions that you are going to rate the presentation on. They should be visible to you on your phone. So you will wait until the number goes up to 51. So while we continue to vote, you can continue to vote while we go back to our presentation. So the second resident will be from the Department of Dermatology, Dr. Maria Bustaimen.
Hello, so my research article today is about plasmacytoid dendritic cells and cutaneous drug eruptions with a lichenoid interface dermatitis pattern. I've tried to make it as simple as possible. So you know that the skin is a common target for adverse drug reactions, among which are lichenoid drug eruptions and fixed drug eruptions, which are considered uncommon but distinctive drug reactions that lichen planus both clinically and histologically. So lichenoid drug eruption mimics LP. It has larger lesions, usually on the trunk and the extremities, spares the mucosa, and is caused by a multitude of drugs like antihypertensives, TNF-alpha inhibitors. And there's a latency period of months to even years between the drug initiation and the appearance of the rash, and this is how it looks clinically. However, FDE is a burning, pruritic, well-demarcated violations to brown plaque that appears on the extremities, hands, genitalia, mucosa, and appears usually 30 minutes to 8 hours after taking the medication and occurs with the re-challenge of the medication. And many commonly implicated drugs are used every day like NSAIDs, Bactrim, Dapsone, among others. So like in lichen planus, LDE and FDE show on microscopy an interface dermatitis pattern where there is vacuolar changes of the basal epidermal layer, apoptotic keratinocytes in the epidermis, and cytotoxic lymphocytic infiltration. Recently, it has been shown that plasmacytoid dendritic cells and their main product, which is type 1 interferon, is the major contributor in the development of certain inflammatory cutaneous conditions with an interface dermatitis pattern like dermatomyositis and lichen planus. So what is the plasmacytoid dendritic cell? It's a specialized dendritic cell population that has several cell surface markers like CD4, CD123, and BDCA2, and it's a major contributor of type 1 interferon in the body. It functions against viruses, it's a link between the innate and the adaptive immunity, and it infiltrates the skin upon injury and not in normal conditions. So our objective was to investigate plasmacytoid dendritic cells and type 1 interferon in LDE and FDE to understand the pathogenesis of these conditions. What we did is that we looked at our dermatopathology database for the clinical diagnoses of LDE, FDE, and LP, and we found 21 cases of drug eruptions with a lichenoid pattern that fit our criteria, and compared them to 21 cases of lichen planus as control. We only included the cases that had a direct cause-effect relationship. The drug was started, the rash developed, and then upon discontinuation of the drug, the lesions disappeared. And then we retrieved the sections, the formalin-fixed sections, and the paraffin-embedded tissue, and did immunohistochemical analysis with anti-BDCA2 antibody, which is a specific marker for PDCs, and anti-MXA antibody, which is a surrogate marker for local type 1 interferon production. And we did a semi-quantitative scoring system. and man-witness test was used to compare the scores between the groups. The patient demographics were not significantly different in age and gender between the different study groups. If you look at the results, the PDC score was mostly 10 to 50% or more than 50% of the infiltrate in all the study groups were composed of plasmacytoid dendritic cells, and the MXA score, which is the type 1 interferon, was an 11 out of 13 and 7 out of 8 was 2 out of 2, so intense staining. And there was no significant difference between the lichen planus group and the drug eruption group. So this is what we see histopathologically. The epidermis is up, the dermis is down. There's between them this lymphocytic infiltrate, this band-like infiltrate with vacuolar changes at the basal layer. And you see the brown staining, which is the staining for the PDCs among this inflammatory infiltrate, and an intense staining in the epidermis and in the band-like infiltrate for the MXA, which is the type 1 interferon marker. And this is the same in another representative FDE case. So several observations allowed us to hypothesize the role of PDC in the pathogenesis of lichenoid drug eruption and FDE. Both LDE and FDE have an interface dermatitis pattern, and plasmacytoid dendritic cells are known to be to play a crucial role in the development of any dermatosis with an interface dermatitis. Second, plasmacytoid dendritic cells enhance a Th1 biased cellular immune response, and this is the basis of LDE and FDE. Third, concomitant viral infections such as HIV, hepatitis, herpetic infections are cofactors in the elicitation of cutaneous drug eruptions. Fourth, in lichenoid drug eruptions, there is an upregulation of CXCR3 ligands, which lead to the recruitment of CD8 cells and plasmacytoid dendritic cells. Fifth, TNF-alpha inhibitors, which lead to the secondary induction of interferon alpha, cause lichenoid drug eruptions, and the exogenous interferon treatment leads to lichenoid drug eruptions. And also in autoimmune disorders like SLE, where plasmacytoid dendritic cells play a crucial role, there is a higher incidence of unfavorable drug reactions. So we are proposing that drug-related antigens may pathogenetically represent an initiating feature in PDC and interferon-associated cytotoxic cellular immune response. So the drug is metabolized by the body, it becomes a reactive compound, and it is present in a milieu in the skin that is rich in antigen-presenting cells. And then the drug, through the formation of toxic metabolites, leads to a danger signal in the skin, leading to the amplification of this pro-inflammatory cascade. So we have, for the first time, identified a central role for PDCs and type 1 interferon in cutaneous drug eruptions with the lichenoid pattern, including LDE and FDE. And thank you.
Thank you, Dr. Boussaïdine. As we did before, it's time to evaluate the presentation number 2. The jury, please remember you have your own code, and for the audience, please use the code displayed on the screen, 299673, and this is presentation number 2. So the code is 299673. So the code, I will repeat it one more time, it's 299673. Now you can proceed with rating the second presentation. So when you vote, we will proceed to the third presentation, representing the Diagnostic Radiology Department, Dr. Mkhail Sebali.
So hello, I'm Dr. Mkhail Sebali. I will be representing the Diagnostic Radiology Department. So the topic of my FRRP project was optic nerve measurement on MRI in the pediatric population, normative values and correlations. This paper was published in AJNR in February 2018, and the mentor was Dr. Ullah. Background. So 4 years ago, I was a first-year diagnostic radiology resident, and I started my radiology residency by neuroradiology rotation, and we were checking an MRI for a pediatric patient, MRI of the brain, and Dr. Ullah was screening and she told me this is a normal optic nerve. As a first-year resident, what's normal for me? How do you know that this size is normal for this age? So I asked her this question and we were unable to get the answer. So I went and searched the literature and there was no normative value. There was only a few articles in the literature that have looked at the diameter of the optic nerve on MR imaging, especially in children. So in whom the observations are subjective and no normative data set existed. So from here I got the idea of doing this project. The rationale Pathologic changes in the diameter of the optic nerve itself are not uncommonly encountered in different diseases, entities affecting the pediatric population, including optic nerve hypoplasia or atrophy, neuropathy, multiple sclerosis, and optic nerve tumors where we have enlargement of the optic nerve. The objectives of the study, as I said, it aimed to report normative values for the optic nerve diameter on MR imaging in the pediatric population and examine its development across different age groups to generate a set of objective measurements for use by radiologists and ophthalmologists. The methods, so our study is a retrospective study on MR imaging of pediatric subjects younger than 18 years of age at the Department of Diagnostic Radiology in AUBMC. It was approved by the IRP. So MR of the head and orbits between January 2010 and December 2015 were screened in all patients that are less than 18 years of age. We had inclusion and exclusion criteria. So the exclusion criteria was any pathology involving the orbits, optic pathway, and brain, because this might affect the normal value or the normal size of the optic nerves. And these are the exclusion criteria: history of any brain tumor, enucleation, optic nerve lesion, ischemia, hemorrhage, etc. So, and the most important exclusion criteria was poor visualization of the optic nerve on MRI. So the MRI should have good quality cuts across the optic nerve. The inclusion criteria were MRI and of the brain and orbit with good visualizations of the optic nerve and absence of any brain and orbital lesion. MRI was performed on 3 and 1.5 Tesla systems. We took the orbit-dedicated stir sequences in the axial and coronal planes. The optic nerve measurements were obtained by 3 raters on axial and coronal sections at 3 and 7 mm posterior to the lamina cribrosa. And this is an example how we got the measurements. So we can see here the lamina cribrosa, and this is at 3 and this is at 7 mm. These are the axial measurements. And to the right, we can see the coronal measurements of the optic nerve also at these 2 levels. So statistical analysis performed with data 13. Inter-rater agreement was evaluated with intra-class correlation coefficients to ensure reliability and reproducibility of the results. After confirming agreement within these 3 raters, we averaged the 3 measurements. Data normally was assessed by the Shapiro-Wilk test. Differences between right and left eyes were evaluated using per-student test or Wilcoxon sign rank test if the data was not normally distributed. And differences between sex differences were also analyzed using the unpaired t-test and man-with-BU test. And ANOVA testing was performed to reveal differences between groups. The results: 211 scans of patients were collected for measurements. Median age of the patients was 8.6 years. 45% of the patients were females. Inter-rater agreement was excellent with an intra-class correlation coefficient of 0.842 and significant p-value of less than 0.001. So these are the first result figures. So we can see on the right the male and female different. We can see that there is no significant differences between the size of the optic nerves among genders, males and females, and on the right we can see that there is no significant difference between the size of between the left and right optic nerves. These are also the results. We can see also significant differences between the different age groups. So at between 6 months and 2 years, there is increase in the size of the optic nerve dramatic, and then between 2 years and 6 years, there is less increase in the size of the optic nerves, after which it plateaus. Discussion: MR imaging was reliable in assessing the size of the optic nerve proper. Previous reports on MR imaging measurements in healthy children focused on the optic nerve sheath complex as a whole and not optic nerve itself. Our data are in agreement with previous literature. No laterality or sex differences are seen. Conclusion: we report normative values of the optic nerve diameter measured on MR imaging in children from birth to 18 years of age. A rapid increase is seen in the first 2 years, and then it has a less rapid increase between 2 and 6 years, after which it plateaus. Our measurements can give radiologists and scientists a reliable reference to diagnose optic nerve abnormalities, and objective assessment by MRI imaging will aid in earlier and more accurate diagnosis. These are the references, and before I end, I would like to finish by a small story which by the lesson that I learned from this FRRP project, and which says that every day we encounter several opportunities for research questions, but we might be missing them because we take things for granted and we do not search about the possibility that this might be good research projects, good research questions for projects. Thank you.
Thank you, Dr. Sfaye. In order to vote for Dr. Sfaye, again, enter the number 299673, and his presentation number is presentation number 3. So I will repeat the code. It is 299673. Okay, so now you can go ahead and submit your ratings. The fourth presentation is from the Emergency Medicine Department, Dr. Noam Fares.
So I am representing the Emergency Medicine Department. However, my study is done in collaboration with the Department of Psychiatry and AUBIC. Our study is about the characteristics and the predictors of hospitalization of psychiatric emergencies in our hospital. In Lebanon, 1 in 4 adults is affected by at least one mental health disorder over the course of their life. The 12-month prevalence of mental health disorders is around 17%. When a patient presents to the ED with a psychiatric emergency, he's being evaluated by the medical team, and then a dispositional decision is made whether to admit the patient to the psychiatry ward or to discharge him home with the outpatient follow-up. To our knowledge, there are no studies that evaluate psychiatric emergencies in Lebanon, or the dispositional determinants of these emergencies. So this was our objective. Our project aimed to identify the characteristics of these emergencies and to analyze the determinants of patient disposition. What would lead the patient to be admitted, or what would cause him to be discharged home. This study was a retrospective, single-center chart review study conducted in the UBMC Emergency Department over the period of 6 months, extending from July 1st, 2016 until the end of December 2016. When a patient presents to the ED with a psychiatric emergency, the psychiatry residents are usually consulted. They come to the ED and they assess the patient, and then they decide whether to admit him or whether to discharge him home and what are the discharge instructions. These residents will log MRNs of the patients on a special log that they have. What we did is that we collected these logs from the psychiatry residents, we built a list of patients, and then we did a short review of all these emergency visits. The total number of the ED visits related to psychiatric chief complaints over the period of 6 months was 195, out of a total of 28,900 ED visits. So the percentage of psychiatric emergencies in our ED in this 6 months period was 6.7 per thousand. This table shows the demographic characteristics of our study population. We had some pediatric patients. 7% of the patients were pediatrics below 19 years. 2/3 of our patients were female, which was an interesting finding. Basically, around 62% of our patients were from Beirut. Most of them also lived with their family, 86%. And 44% were paying out of pocket, either because they don't have insurance coverage or because the insurance didn't cover their admission. The most common diagnosis was depression, followed by anxiety, but we also had presentations of multiple mental health disorders. Out of the 195 psychiatric emergencies presented to our ED, 107 patients required admission. 88 of these were discharged home. However, out of those 107 patients who required admissions, 32 left against medical advice. Among the factors, patient factors, the suicidal ideations, suicidal attempt, the lack of insight, and having depression were factors significantly associated with with being admitted. However, the diagnosis of anxiety, patients who have anxiety were being discharged most of the time. This table also shows patient characteristics and the relationship to disposition. Female gender was associated with the admission, and also paying out of pocket was also associated with the admission. This table shows the multivariate analysis. Females were more likely to be admitted, so having suicidal ideations, having a lack of insight, were also predictors of hospitalization, whereby patients were more likely to be admitted. Patients with anxiety were less likely to be admitted. So in conclusion, the factors found to be associated with the hospitalization were the following: female gender, suicidal ideations, suicidal attempt, the lack of insight, being depressed, and having substance abuse. The proper dispositional decision was confounded by social and financial factors, whereby 18% of patients left against medical advice. Proper mental health laws and policies are needed to ensure the adequate care of patients with mental health emergencies. And thank you.
Thank you, Dr. Faris. So for the audience, again, please enter the code 299673 and specify that this is the presentation number 4. It's 299673. I will display the instructions one more time. And this is presentation number 4. Now you can go ahead and submit your ratings for the 5th presentation from the Department of Family of Medicine, Dr. Mario Shahruri.
Okay, good afternoon everyone. So I will be presenting a research project that I did with Drs. Hassan Hadi and Salim Nadeem, whom I thank. And our project started as a straightforward question that I got from one of my patients who asked me out of the blue, where did you go to high school? And more about me means myself as a physician is a study about the patient's response to physician self-disclosure. So what is physician self-disclosure? It is defined as any statement made to a patient that describes the physician's personal experience. And from what we know in the previous literature, patients do like their doctor's philosophy and hobbies information, and even they like to know about their personal life and character in one of the studies. And when we asked physicians, or when they were asked in the literature, we found they also find this self-disclosure as positive. However, there was no single study in the literature that shows how this information from the physician will affect the patients in terms of satisfaction or even the patient-physician relationship. And this is where we thought that physician self-disclosure itself has a potential benefit in improving this relationship and as well this today's very hot topic, patient-centered care. And at the same time, it has the potential to advise physicians on how to respect the boundaries with the patients and at the same time protect their privacy. And so our primary objectives were first to measure the prevalence of this disclosure, mainly by asking patients how and through their lifetime if they ever perceived this information, and to explore how the patients respond to this physician self-disclosure. And secondarily, we wanted to know if there are any socio-demographic or health history factors that could affect response. And so what we did is we asked patients or participants who were from 20 to 65 years of age who presented to the family medicine waiting area from June and July 2017. Data collection was thankfully done by MRVP volunteers. It was convenience sampling, and it was a mixed method study with qualitative and quantitative. The quantitative part was a self-administered questionnaire, and the qualitative part was open-ended questions, which I will discuss in a few. So the main variable was prevalence, demographics, health characteristics, and the patient response. How do you measure those? So first, prevalence, we came up with a question which is, in summary, your doctor might share personal information with you in any clinical encounter. Have you ever perceived this? Yes, no, and if yes, if it's once or more than once. And as in terms of response, we adopted vignettes from a previously done study in 2004, although it was done on physicians, but we adopted it and made it work on patients, and it included 9 different themes. And I will take only 2 examples of vignettes here. One, the first, which is from physical activity, which says, it is important to find exercise you enjoy. I take a class at the gym, and it's a great stress reliever and keeps me active. And from another side of the spectrum, one mental illness statement is, I also suffer from panic attacks from time to time, so I can help you through this. And so we recruited 620, we approached 629 participants, which we got from 421 enrolled, and we reached our sample size. And the response rate was almost 70%. So this table represents the population characteristics. We had factors that are socio-demographic, such as age, gender, perceived income, and education. And the health variables that I told you about are the perceived health status, chronic diseases, and within the previous 12 months, recent hospitalizations and visits to a doctor. And I can tell you in summary that our population was mainly young, less than 40 years of age, women mostly 60%, satisfied with their income almost 70%, 90%, and they had acceptable health. And so the prevalence measured was almost 1 out of 5. So 1 out of 5 patients perceive physician self-disclosure, which is 22.9%, and it's comparable to previous prevalence studies that we had. 2 main, one is 17% and one is 28%, but they were done from the physician side and not from the patient side. And looking again at any association that we had, so this table represents mainly the discrimination between those who had any report of disclosure and those who didn't, and we couldn't find any association with the fact that they perceived the disclosure and the socio-demographics or health characteristics. As you see, all p-values done by varied analysis were not significant. And so this main quantitative chart shows us the response and the percentage of positive, negative, or neutral answers. And as you can see, the most positive answer was almost 82% that got a response was about physical activity. And the most negative was the cancer, because it was a negative statement, and the most neutral was about divorce. So if you're telling me about your relationship, I don't care to know much about it. And so from the thematic analysis that we had after we got the open-ended questions, we could say it's positive, the physical activity, because it's mainly motivating. Negative, because they think it's frightening and disruptive, and here I select one comment, say something cheerful or shut up. This is what one of the participants wrote. And when it's neutral, it's mainly because it's irrelevant and relative to the physician's experience. And so in conclusion, we can say confidently that physician self-disclosure is prevalent in any encounter and among all specialties and patients from all areas. And at the same time, we know that the response is positive mainly with 3 conditions. When it is reassuring, when it is relevant, and when it is brief and non-disruptive. And here we can conclude that physicians need to choose, and all of us need to choose, what to share with our patients. And at the same time, I do believe that this self-disclosure should be part of the communication skills training for future and current doctors. And thank you.
So now for the audience, please enter the code number 299673. And since we are a bit late in schedule, we will do one more presentation. Then we will head out for the second poster session. Then we will come back in and we will carry on with the remaining 7 oral presentations. Just because we want to stick to the schedule Dr. Shahid Matar.
Hello everyone, I'm Shahid Matar, representing the Department of Internal Medicine. Today I'm going to present my FRP project entitled Anticoagulation for Perioperative Thromboprophylaxis in Patients with Cancer, a systematic review. So as a background, patients with cancer are at high risk of thrombosis. The choice of appropriate perioperative thromboprophylaxis depends on the relative benefits and harms of different anticoagulants, mainly low molecular weight heparin, unfractionated heparin, and fondaparinux. Until date, there is no consensus on the superiority of one anticoagulant versus the other. For that, the objectives were to systematically review the evidence of the relative efficacy and safety of the anticoagulants for perioperative thromboprophylaxis in patients with cancer. So our PICO questions were as follows. The population of interest, it was patients with cancer undergoing surgery. The intervention was anticoagulants, including the unfractionated heparin, low molecular weight heparin, and the fondaparinux, and the control will be any other anticoagulant. The outcome, initially we were interested in 13 outcomes. I'm going to state the most important: mortality, pulmonary embolism, symptomatic deep vein thrombosis, major bleeding, and wound hematoma, and the follow-up time was a period of 30 days post-surgery. The study design that were interesting for us was only randomized clinical trials. The search methods we used was a major electronic data search until date of January 2018, including the Cochrane database, the Medline, and the Embase. And also we did additional search, including the ASH and the ASCO websites for any conferences, any abstract related to our topic. Also we did the PubMed and the Web of Science, and also we searched for ongoing studies in the website of WHO, ICTRP, and the clinicaltrials.gov. To mention that on a monthly basis, we're doing update to our search methods, since this systematic review is a part of a series of living systematic reviews that our team is leading in collaboration with the Cochrane Library. So data collection, we use a standardized form to extract data in duplicates and independently concerning the characteristic of the included studies and the number of events per arm, as well as number of participants randomized per arm. Data analysis. So for the risk of bias assessment was based on the Cochrane risk of bias tool. As for the measure of association, we use for the dichotomous outcomes, we use the relative risk, and for the continuous outcomes, we use the mean difference with the random effect and the mental Hensel statistical method. To mention that we assessed the certainty of evidence for each outcome using the grade approach. So the research ended up with this PRISMA flow diagram. Initially, we had 15,476 records that were captured. After removing the duplicates, we ended up with 7,351 study that underwent a title and abstract screening. After that, 166 study underwent a full text screening, and 19 randomized clinical trials met our PICO questions and were included in this systematic review. So 19 randomized clinical trials shown here in the table with 9,655 randomized patients. Characteristics of included studies. This is an example of a table of one study, which is Agnelli 2005, and all the characteristics abstracted from this RCT. And this is the table representing the risk of bias assessment for this specific study. So after doing all the risk of bias, this is the risk of bias graph that is across all the included RCTs. In green, we have a low risk of bias. In yellow, we have unclear risk of bias, and the red indicate high risk of bias. And we can see clearly that the majority of biases had low risk. Next, the main results. So this systematic review was able to identify two arms. First was low molecular weight heparin versus the unfractionated heparin with 13 outcomes as mentioned. The only clinically significant outcome was the wound hematoma. And this is the first plot of this wound hematoma outcome. First, in the first part, you can see the studies included in this outcome, the event per arm, and the risk ratio. And in total, we have the risk ratio total that is clearly seen that it's in favor of low molecular weight heparin. With a risk of bias, most of them was low risk of bias. And summary of findings for the other outcomes that I'm not going to state for now. And the second arm was low molecular weight heparin versus the fondaparinux. We're able to have 4 outcomes, and the venothromboembolism event were clinically significant. As you can see here in the first plot, that is clearly clinically significant that the risk ratio is in favor of fondaparinux when it comes to VTEs. And this is the summary of findings for all the outcomes in this specific arm. So as a conclusion, there was no differential effect between perioperative thromboprophylaxis with low molecular weight heparin versus the unfractionated heparin when it comes to mortality, thromboembolic outcomes, or major bleeding in patients with cancer. But low molecular weight heparin had less incidence of wound hematoma when compared to unfractionated heparin. As well, the available evidence suggested that fondaparinux may reduce the risk of venous thromboembolic event relative to low molecular weight heparin. So as an application for practice, given the lack of clear evidence of superiority of one drug over the other, as a result of this imprecision, clinicians should base their choice on cost and patient preferences using an individualized decision-making process. As the current status of this systematic review, it has been accepted by the Cochrane Library and undergoing editorial review and will be published hopefully soon. I would like to acknowledge the authors, the co-authors that contributed to this systematic review. And finally, the results of this systematic review was used as the basis of recommendation and a clinical practice guideline for the thromboprophylaxis guideline by the American Society of Hematology in collaboration with the AUB Great Center. Thank you.
Now again for the audience, if you would like to rate Dr. Sharbel Matar's presentation, please put in the code 299673, and this is presentation number 6. And now you can submit your ratings. And as I mentioned before, we will now postpone the pre-scheduled 7th presentation for after the poster session. So we will all go out to the lobby again for a 30-minute poster session.
Mean time to actually was 18.4 seconds. And I will take the
We will start with presentation number 7, which is from the Neurology Department, Dr. Jawad Milhan.
Good afternoon. So my study today will be about children's entitled Predictors of Epilepsy in Patients with Periventricular Achalasia. It's a formatic study of the parents. So as you all know, periventricular achalasia is a disease of children, of mainly premature babies, and it's a leading cause of developmental delay and neurological disability. And studies have shown that around 1/3 of patients with PVL will develop epilepsy at some point. So up till now, there are no predictors of epilepsy, and specifically no radiographic predictors of epilepsy in these patients. The objective of this study is to quantify the correlation between thalamic volume and risk of developing epilepsy in such patients. And as a secondary objective, we'll try to devise an epilepsy model that stratifies such patients into levels of risk. And we'll incorporate in this study clinical data also. So this is a retrospective type of study. We went through the PAC system. We searched for MRIs with radiologically confirmed PVL between 2010 and 2014. And they should be patients that are 10 years of age or younger, and they should have high quality MRI, which means it should be done on 1.5 Tesla or 3 Tesla with a 1 to 3 millimeter slice thickness. Of course, we enrolled also controls, and these patients should be normal. They should have normal MRIs, and usually they have done MRIs for non-neurological causes such as ENT causes, and they should be healthy, which is they should have normal development and they should not have a history of seizures. So the methods are simple and clear. We went through radiographic data and clinical data. The radiographic data were extracted in sequential manner and they were analyzed in sequential manner by an experienced neuroradiologist here at AUB in a single blinded manner to clinical data. So the first level of assessment will be qualitative data, which are the visual features of such MRIs. The second level of analysis will be the quantitative data, where we'll take 2D measurements of the thalamus. And the third level will be also quantitative, but will deduce the volumes of thalamus in such patients. So as for the first level, here you can see example of two patients with PVL. These are 7 years and 4 years of age respectively. And here we will do visual assessment. We'll look for atrophy and signal abnormalities in the gray matter, white matter, and deep structures. The second level will be 2D thalamic measurements in the anteroposterior and transverse plane on axial cuts. And we will take the cut with the logic parameter. So here is also an example in which we measured the left thalamus anteroposterior and transverse diameter. And to ensure consistency and reproducibility of data, we used published studies on predefined thalamic borders in the anteroposterior, superinferior, and mediolateral planes. In the third level of assessment, we will do 3D thalamic measurements, and these are volumes that are derived through a computer-generated mask. And here you can see an example in a healthy patient in which the upper graphs show the segmentation pattern of different brain structure, and in the lower graph, these are equivalent segments of the upper ones. And after we take this segmentation that are computer generated, we will have to re-examine them manually to redefine the boundaries, looking for any computer mistakes. So eventually we'll have a 3D thalamic mask, and this is an example of a left thalamus here. As for the clinical data, these were reviewed for all patients, and accordingly we divided the cohort into two groups. Group 1 are PVL with epilepsy, Group 2 are PVL that are epilepsy free. And we studied multiple variables, including developmental milestones, the type of cerebral palsy, time to index seizure, type of epilepsy, and electroencephalographic abnormality and duration of follow-up. So as for the results, actually we are still early in the study. In total, till now, we include only 27 patients with PVL, and only qualitative assessment was done, so we are still stuck with the level 1. As you will know, these methods are time-consuming, so the progress is slower. The mean age at MRI acquisition was around 2.1 years, with a slight male prevalence, and most of them had developmental delay. 13 patients, with almost half of the cohort, developed epilepsy at one point, with the mean age at onset of an index seizure was 5.3 years. The most common electroclinical syndrome was symptomatic Giant's epilepsy. As you all know, and a well-known example would be West syndrome. We all are familiar with this. On visual inspection, the thalamus was found to be atrophied in 13 out of 27 patients, and in those with epilepsy, 9 out of 13 had an atrophy, which is 70%, and those that are epilepsy-free, 40% or 6 out of 14 patients had atrophy. This was statistically significant for an association with development of epilepsy. Of course, these results are only limited to the early phase, the qualitative phase, and these are encouraging results to pursue to recruit more and more patients and go ahead with the quantitative measurement. So it's very important to do a risk model to certify risk of epilepsy in such patient, as the thalamus would be a good surrogate market of cortical neuron dysfunction because of the extensive corticothalamic connections. So, thank you.
Yeah.
Okay, now for the audience, please, if you can evaluate Dr. Milham's presentation, go to menti.com and enter the code 299673. I would like to remind the jury that they have a different code number. So the code is 299673, and this is presentation number 7. And now you can enter your ratings. Our next presentation is presentation number 8 from the Obstetrics and Gynecology Department, Dr. Ali Murad.
Good morning, everyone. Dear fellow colleagues, dear residents, friends, students, and attendings, I would like to take a few seconds of my time to thank and show gratitude for the people that offered me all the help and support I could ask for to complete my project. Thank you, Dr. Dina Shamsi, and thank you, Dr. Karam Karam. So my project is entitled Uterine Hysteroscopy versus Abdominal Metroplasty for the Management of Septate Uteri, Review of Safety and Reproductive Outcomes. In order to understand the rationale for our study, one must understand the pathology itself. So we have to know what is lacking in the literature in order to provide our patients with the best quality of care. So uterine septum is the most common type of congenital uterine anomalies, with a prevalence of 2.3% in the general population. During embryogenesis, the two Mullerian ducts fuse together to form a single uterine cavity. Incomplete resorption of the midline septum leads to what we call a septated uterus. Though occasionally associated with infertility, this pathology is commonly seen in women with recurrent miscarriages, mainly due to the fibrotic nature of the septum affecting implantation. To correct this congenital anomaly, two procedures were described: abdominal metroplasty and hysteroscopic septoplasty. Abdominal metroplasty consists of removing a wedge from the uterus, including the septum, while hysteroscopy is a minimally invasive surgery that cuts through the septum. Unfortunately, the literature lacks any comparative study of the efficacy and safety of the two surgical techniques. In fact, some clinicians still argue that metroplasty is even better than hysteroscopy, since the septum will be completely removed with the metroplasty technique. The objective of this study is to compare the safety and efficacy of abdominal metroplasty versus hysteroscopic septoplasty. The primary outcome is the live birth rate, and secondary outcomes include fertility rate, rate of first and second trimester miscarriages, and operative complications. This project consists of a retrospective chart review. After obtaining IRB approval, patients who have undergone abdominal uterine metroplasty and hysteroscopic septoplasty from January 1974 until December 2016 were identified. Data was collected from their medical records and analyzed. In total, 132 patients with septum were identified, 25% underwent abdominal uterine metroplasty, and 75% underwent hysteroscopic septoplasty. Patients in both groups had similar demographic characteristics and pre-treatment obstetrical outcomes, such as an increased rate of first trimester abortions, around 60%, second trimester abortions, around 20%, and infertility, around 30%. Correction of septum through hysteroscopic septoplasty led to improved pregnancy outcomes, as you can see, leading to a significant decrease in first trimester abortions from 58% to 30.3%, a decrease in second trimester abortions from 20.2% to 3%, a decrease in infertility rates from 30.3% to 10.1%, and finally, an increase in live birth rate from 32.3% to 75.8%. Correction of septum through metroplasty led also to improved pregnancy outcomes, as you can see, leading to a significant decrease in first trimester abortions from 63% to 36%, a decrease in second trimester abortions from 24.2% to 6%, a decrease in infertility rates from 24% to 9%, and an increase in live birth rate from 27% to 72%. When comparing both surgical techniques, no difference was noted for first trimester abortions, second trimester abortions, infertility, and live birth rate. However, with abdominal uterine metroplasty, the immediate postoperative complications and the estimated blood loss were significantly higher than hysteroscopy. We're talking about 300 milliliters versus 50 milliliters for metroplasty and hysteroscopy, respectively. Moreover, time to pregnancy was significantly longer in the metroplasty group. We're talking about 21 months versus 4.2 months in the hysteroscopy group. And finally, the mode of delivery was mainly through cesarean sections. We're talking about 66% in the metroplastic group, which is a very high percentage, versus 19% in the hysteroscopy group. In conclusion, this is the first study comparing the outcomes of abdominal uterine metroplasty and hysteroscopic septoplasty. Both techniques improve obstetrical outcomes. However, abdominal uterine metroplasty has greater risk of immediate and long-term complications. Therefore, hysteroscopic septoplasty should be the standard of care for the management of septated uteri. Finally, this stresses the fact that residency training should focus on developing advanced hysteroscopic skills so that patients can benefit from the advantages of minimally invasive gynecological surgery. Thank you.
Thank you, Dr. Murad. In order to vote for Dr. Murad, the audience, please access www.menti.com and enter the code 299673. The code is 299673. And now you can submit the ratings. As for the second presentation, it will be presentation number 9 from the Department of Ophthalmology, Dr. Huda Shaiti.
Good afternoon, everyone. So thank you for being here. Thank you, Dr. Hamam, for your support. Our study is about ocular tuberculosis. So ocular tuberculosis is actually any type of eye inflammation that is due to tuberculosis. And it was initially described in areas that are endemic to tuberculosis. And more recently, it's being recognized also in non-endemic areas. Now, also there's data showing that there's a portion of patients that are diagnosed as idiopathic uveitis. They are actually due to tuberculosis and they're misdiagnosed. Now, usually steroids and immunosuppressive therapy are used to treat inflammation, and they're used to treat uveitis, that is the idiopathic uveitis, and this is how this diagnosed ocular TB ends up being treated with steroids. Additionally, we also add steroids for the treatment of ocular tuberculosis along with anti-TB therapy sometimes to try to control the inflammation. So we wanted to do the study first to actually characterize patients in our area, which is the Lebanon and non-endemic area, and to try to evaluate the outcome and evolution of their disease after anti-TB therapy, and maybe identify possible risk factors that may impact their prognosis, including the use of steroids. So it was a retrospective analysis of patients. It's a chart review of patients diagnosed with presumed ocular tuberculosis from 2009 till 2015. So the inclusion criteria is basically patients that were diagnosed with presumed ocular tuberculosis, which is basically someone presenting with a suggestive clinical picture, a positive PPT test, a negative systemic workup, and a positive response to anti-TB therapy. So they have to respond well to the TB therapy to diagnose them with that. Exclusion criteria would be anyone who has uveitis that could be explained by any other systemic disorder. We ended up having 33 eyes with 10 patients, and we collected the data for their presenting features, clinical course, and how it evolved after treatment. These are the tables. In table 1, the most important thing to note, the most important thing to note is that 50% of them presented with recurrent uveitis attacks. And a quarter presented with acute attacks, so you also have to keep in mind that it's their first presentation. Now, in uveitis, we have types of uveitis, anterior, posterior, and panuveitis, and the most common in our series was posterior uveitis, and panuveitis, followed by posterior uveitis. Only one patient had anterior uveitis. Now, the majority of our patients had a good visual potential at diagnosis, something to keep in mind that they had 20/40 vision and better. If you look at table 2, these are the different inflammatory manifestations, and you can see that most, if not all, of the inflammatory manifestation actually improved after treatment, and that was statistically significant. And that the most common complication associated with the uveitis was macular edema. This usually affects vision the most because it's a center of vision, and this also improved significantly on treatment. This is a fundus photography of a patient with a solitary granuloma due to tuberculosis, and how it improved and actually resolved after 2 months of treatment with anti-TB therapy alone. And this patient actually had a good visual acuity because the center of vision, the macula, the black area there, was not affected. So they not all have bad vision when they present. The treatment included anti-TB therapy for all. Our time interval was not standardized, but they all received at least 6 months of treatment. The most important thing is that there was a significant improvement in their visual acuity scale, the Logmar scale, at 6 months from 0.48 to 0.7. And also that all the eyes showed improvement in their inflammatory reaction at treatment. Different manifestations require different times to resolve, with the macular edema needing up to 9.5 months. Now, when we looked at the steroid use, around 19 eyes out of the 33 required additional steroid use added on to the anti-TB therapy, be it oral or injections in the eye. And overall, when we looked, there was no statistically significant difference in terms of vision improvement, visual acuity improvement, macular edema resolution at 6 months between those that received only anti-TB therapy and those that had TB therapy along with steroids. So basically, our study showed that similar to studies in the literature, the most common presentation of TB uveitis is posterior panuveitis, and we were actually able to see a presentation which is serpiginous lichoroiditis, which is usually seen in TB endemic areas. We had 5 eyes that had that in Lebanon. Steroid use did not really worsen their visual acuity in the end. So although we did not have significant result, but at least we did not see that they had worse outcome. And that something to keep in mind is that some of the manifestation needed up to 9 months to resolve and improve. So it's very important to realize the importance of prolonged treatment in these cases. This is a retrospective study, a small sample, and the treatment was not standardized among the patients, so we cannot really conclude results on steroid use from here.
waiting for more future randomized based studies to be done on this. Okay? Thank you.
So this was presentation number 9. Access20.com and enter the code 299673. And this was presentation number 9. So if you just walked in and you're in the audience and you would like to evaluate the presentation, access20.com, enter the code 299673, and this is presentation number 9. You can now submit your evaluations. As for the presentation number 10, it will be from the Department of Pathology and Lab Medicine.
Good afternoon. My name is Nada Assaf. I'm a PGY4 clinical pathology resident, and I'll be presenting to you today my research project entitled Genetic Profiling of Adult Acute Myeloid and Lymphoid Leukemias Cases in a Major Referral Center in Lebanon. My advisor for this project was Dr. Rami Mahfouz. For the outline of my presentation, I'll start first with the background, just to put things into context. Then for the aims of our study, to try to convince you why the study was important to be done. Then I'll go through the methods we used, the results we obtained, and finally I'll end up with the conclusion and our references. So first with the background, I want to introduce you to a book which was published by the WHO in 2016. This book is the major book that aids clinical pathologists in the diagnosis of acute myeloid and lymphoid leukemias. And as you can see here, there are two important categories that were published by the WHO, which were the AML and the ALL with recurrent genetic abnormalities, being distinguished as single classes within the other AML and ALLs. Why is it important to know the genetic abnormalities of acute leukemia? It's first because they confer distinct pathologic features, then because they aid us in the determination of the clinical behavior, in the prognosis, and finally in the appropriate treatment to be undergone. So for example, if we know that the patient has a translocation 1517, we can expect on the morphology to have blasts that are hypergranular. Here you can see the fatty cells seen on the bone marrow aspiration, just because the patient has a T1517 translocation. And now we know that we can use all-trans-retinoic acid as a treatment. In this WHO book that I talked to you previously, there is a published frequency for each of the translocations and the mutations. However, in the literature review, it was shown that numbers diverge in different areas of the world. And in the MENA region, there was no study that published both AML and ALL genetic profiling. There was only one study in Lebanon, done in Lebanon, that was only for AML cases, and it reported a higher occurrence of promyelocytic leukemia. So what did we do is that we did the genetic profiling of all adult leukemia cases, AML and ALL, that presented to our tertiary over a 10-year period. So for the aims of our study, we tried to determine the frequency of those translocations, both for AML and ALL, only for adult patients, and then we compared the frequencies to the genetic profiling that is published in the international literature. And this is important because it gives us an insight into the identity, the behavior, and the burden of acute leukemia in our center in terms of treatment and later for the need of stem cell transplantation. For the methods, we took all Lebanese patients that presented to our lab for genetic profiling. The duration was for 10 years, so from January 2006 until June 2016. And we did a retrospective review of laboratory results from our laboratory information system. The panels that we performed are panels that are performed internationally for the diagnosis and prognostic classification of acute leukemia, both myeloid and lymphoid leukemias. I don't want to confuse you with the multitude of translocations that we did, but as you can see here, there are specific panels for AML and for ALL, translocations and mutations for AML, and translocations only for ALL. What was interesting in our study first was the high number of patients that we had. In fact, we had 580 AML cases and 175 ALL cases. Of course, we had fewer ALL cases because we targeted only the adult population, and as you all know, ALL is mostly a disease of childhood. For the epidemiology of our cases, we had the same male to female ratio as the international literature. However, what was interesting is that we had lower mean ages at presentation. You can see, for example, for the AML, we have 50 years versus 65 years published in the international literature, and 37 years for BALL and TALL versus 50 years published in the international literature. What was very interesting is that when we did a study over the literature, we found out that in fact the lower the socioeconomic factors present in a country, the lower the age, the mean age of presentation of acute AML and ALL cases. For example, when we took all Arab countries, we had the same age of presentation as the one found in our study. And when we went to study cases that were found in Africa, for example, we had even lower results for the mean age at presentation. Now for the translocations, we found two main interesting findings. We had statistically significant differences both in the inversion 16 and the T922 translocations. In fact, we had a lower percentage for the inversion 16. Inversion 16 is a good prognosis marker. However, this was not worrisome for us because we all know that inversion 16 usually comes in children or in adolescents and young adults. But in our case, we took only adult patients, and this might be the cause why we had a lower frequency of inversion 16. For the higher frequency of T922 in our AML population, we noticed that in the Arab region, mainly in Egypt and in Tunisia, we had also this higher percentage of T922, which is a bad prognosis, unfortunately. However, we noticed that in one study done in Lebanon, they did not have the same high percentage of T922, but in this study, in fact, we noticed that they use only one type of mutation. For the other mutations, so not the translocations for AML, we had the same frequencies as the one published around the world. Then for the AML risk stratification, we noticed that we have a risk stratification that is similar to what's found around the world, with the highest percentage being in the intermediate group. For the BALL cases, we had the results which were similar to the international literature, except for slightly lower T922, and T922 is usually found in the elderly, and because we had a lower mean age at presentation, it might be the cause why we had a lower T922. However, for TALL, we did not obtain any genetic mutation for all the cases that we studied. So as a conclusion, the interesting findings that we had were first the lower mean age of presentation. For the AML cohort, the interesting findings were the lower percentage of inversion 16 and the mild increase in Philadelphia positivity, whereas in the ALL cohort, we had a T922 positivity, which was less than expected for adult lymphoblastic leukemia. And because for TALL cases we did not have any genetic modification, it is safe to extrapolate that full molecular profiling is still needed for our cases, mainly by next generation sequencing, which is much more sensitive than RT-PCR that we used. Thank you.
So this was presentation number 10. Please access menti.com and put the code 299673. So if you are with the audience, go to www.menti.com, put the code 299673 to evaluate the presentation, and this was presentation number 10. While we wait for more voters to start, while we wait for more voters to log in, I would like some feedback on menti.com. Anyone from the audience? Was it a good software for you to get engaged? No one?
It was very good.
Okay, so I have feedback from the jury. It was very easy. Thank you. Only 6?
End of the day. There's a problem.
End of the day, okay. So as you see here on the bottom right, I can see how many people are actually voting. So usually I'm waiting.
So it is for us that we have already voted on this question.
It said that you voted for this question. So try to refresh. Okay, and in the meantime, the people that already logged in can vote. For the next presentation, it will be presentation number 10 by Dr. Farah Faytouni. 11, sorry. Dr. Farah Faytouni.
So hi everyone, my name is Farah Faytouni and I'm a PGY3 resident at the Department of Pediatrics and Adolescent Medicine, and my advisor for this project is Dr. Lama Sharafuddin. So our research project is about knowledge, attitude and practice of childhood vaccination among Lebanese parents, the case of influenza and human papillomavirus vaccines. So background, anti-vaccine movements are on the rise in Lebanon, and immunization rates are only reaching 85%. Thus, we are facing a recent resurgence of preventable diseases. HPV and influenza vaccine administration remain suboptimal in our area. Our objectives. So our primary objective was to study the knowledge and attitude of Lebanese parents toward vaccination in general and their reported practice against vaccine, in particular influenza and the HPV vaccine. Our secondary objective was to study the rates and causes of influenza and HPV vaccine refusal among a sample of Lebanese parents. The methods. So a cross-sectional anonymous survey was conducted between April and November 2017. The survey questionnaires was distributed to parents in randomly selected 2 public and 2 private schools in Greater Beirut area. The target sample size was estimated to be 400 based on similar studies. An Arabic questionnaire was developed based on previously validated questionnaires. The questions were grouped by themes, and the answers had 5-element Likert scale, and then the Likert scale answers were transformed into a score over 100. And the data analysis was done using the SPSS version 24. Now the results. 331 out of 455 distributed questionnaires were returned with a response rate reaching around 73%. Sample characteristics. So the survey were most likely filled by mothers of children in the middle school. And as you can see, Vaccinated children against influenza are more likely to come from private schools, although it wasn't statistically significant. However, parents with a middle to high income are more likely to vaccinate their children against influenza compared to parents with low household income, and that was statistically significant. To note that influenza vaccine is not a mandatory vaccine, and thus it's not covered by the Ministry of Health. So, 71, as you can see in this pie chart, 71% of parents answered that they don't vaccinate their children against influenza. Regarding the HPV vaccine, 40% were not even aware of its existence to start with, and 36% reported that they have not or will not vaccinate their children against HPV. And of the parents who were aware of the HPV vaccine, 60% said they will not vaccinate or give it to their children. Now, what about the association between knowledge, attitude, and influenza vaccine? So as you can see in this table, parents who are more likely to vaccinate their children against influenza scored higher in the questions of general knowledge. They thought that vaccines were more effective and safe. They had more trust in their pediatrician's recommendation and showed less hesitancy toward vaccines in general, all of which were statistically significant. What about the association between practice and influenza vaccine? Interestingly enough, 52% of parents who don't vaccinate their children against influenza reported not being recommended by their pediatrician, and 32% were hesitant that it's still a new vaccine, and 23% consider that getting the flu is not fatal, thus they won't vaccinate their children against influenza. Patients who don't vaccinate their children against influenza were found also to refuse or delay other vaccines, mostly because they think they were not needed or because of fear of needles. So vaccinated children against influenza also were more likely to receive all other vaccines and not only the mandatory ones, as in the non-vaccinated children group, because we can relate this to financial reasons. So in conclusion, a gap in knowledge, attitude, and practice of vaccination is still present in the urban setting in Lebanon, and more awareness is needed not only among pediatricians but also among parents alike. The limitations of our study were the target sample size that was not reached, and because our study was limited to an urban area. However, we suspect that these results are an underestimate of those from rural areas. The strength of our study were mainly the high response rate, reaching around 73%, and the inclusion of private and public schools. Thank you.
So this was presentation number 11. So now from the audience you can access menti.com and enter the code 299673 to evaluate the last presentation, and it was presentation number 11. And now you can start the rating. As for the next presentation, it is presentation number 12 from the Psychiatry Department, Dr. Zainab Bazi.
Good afternoon, everyone. My name is Zainab Bazi, psychiatry resident. I will be presenting our study, Cannabis Use and the Relationship to Psychosis in a sample of Lebanese psychiatric patients. So basically, cannabis use has been associated with increased risk of mental illnesses and more specifically psychosis. It is suggested that cannabis use exacerbates psychosis and worsens the course and outcomes. The prevalence of cannabis use when we did the literature review was varied actually from study to study. It ranged from 5% to 60% across studies, and specific characteristics, associated factors were mentioned throughout multiple studies. It was noted that alcohol was another predominant substance of abuse in psychotic patients. No studies addressing this topic was done in Lebanon to our knowledge, and we were interested in finding the prevalence of cannabis use in the psychiatric inpatient, where patients were admitted with psychotic symptoms in ABMC, the inpatient in ABMC, and we aimed to find association between the symptoms, the course, and specific characteristics, if we could find any, between cannabis and psychosis. So in order to do that, we did a retrospective chart review for the past 5 years for all the patients who were admitted with psychotic symptoms to the inpatient unit. And basically this is the flow diagram of the study. Around 1,600 admissions were screened, 750 charts, around 750 charts were eligible for evaluation. Up till now, the study is still ongoing. Up till now, we evaluated manually 300 charts, and 127 patients were included in this, fulfilled the criteria and will be included in this presentation. So we will include descriptive statistics, associations to categorical and continuous variables. And as I mentioned before, the study is still ongoing, and more detailed analysis and correlations will be coming in the near future. Okay. So basically, the prevalence, we move to the results. So the prevalence of cannabis use among inpatients with psychosis was found to be 22.8% in our inpatient unit. Most of the patients were males, more than 95% actually were males. And there was a distribution among multiple primarily psychotic and mood disorders. So as you can see, substance-induced psychosis is 90%, had 90% incidence prevalence of cannabis use, but also it was worth noting that other severe psychiatric disorders had also almost a quarter of their patients with cannabis use. So we tried to find a correlation with the age, duration of inpatient stay, and the duration of the psychotic episode, and only age was correlated with cannabis use, and cannabis users were found to be younger than non-cannabis users. When looking at demographics and other characteristics, basically only the relationship status was found to be significantly different among the two groups, and cannabis users were more likely to be unmarried. Concerning symptomatology and presentation of cannabis users, no significant difference was found among the two groups, although previous literature suggests that the course might be different. But in this study, we could not, up till now, we could not find any significant difference. However, when we looked at nicotine, alcohol, and other substance use, basically amphetamine, cocaine, opiate, hallucinogens, and benzodiazepines, basically most of them were significantly associated with cannabis use. Only benzodiazepine use was not. It was worth noting when we saw that only 19.8% of the psychotic inpatients were screened for substance use. And we will use that to stress that we should ask for unit toxicology for every single patient presenting at least with psychosis, maybe. So what I would like to discuss with you, so the prevalence that we found was similar to another study done at the University of Michigan, and they had similar characteristics, male young. The absence of the statistical significance to symptomatology might be due to the low power, as I mentioned, we did not finish our study, due to selection bias being in patients extremely sick, maybe a ceiling effect, or due to the non-quantifiable nature of our data collection, maybe the need of scales to assess the severity of we just qualified symptoms. Family history was positive for psychiatric disorders in 70% of cannabis users, putting them at high risk to start with. However, we did not look for a family history of psychotic disorders, and we will be trying to do that in the future. Cannabis use was associated with use of multiple other substances. This may raise the question of the gateway theory. However, this cannot be answered from our study. We will need follow-up studies for that. Also, this might be important so that maybe when we see a patient with cannabis use, we will screen for other substance use. And around 20% only of the inpatients were screened for the urine drug screen. This might underestimate our prevalence and might affect our management, thus the importance of screening all patients. A better understanding of this obscure interaction between cannabis use and psychosis might help in preventing, improving this specific population, or maybe subgroups at risk within this population. And I will be concluding again. So around a quarter of patients with psychosis admitted at ABMC for treatment were found to use cannabis in this sample. There was no statistical significance in symptomatology or course, and cannabis use was associated with the use of multiple other substances. Our results thus highlight the importance of screening, referring for rehab, and basically urine tox, and screening for other substances when cannabis use is found. Thank you. These are my references. Thanks a lot.
Thank you, Dr. Brazil. This was presentation number 12. If you would like to rate this presentation, please access www.menti.com and put the code 299673. So again, if you just entered and you know the audience and would you like to evaluate the presentation, go to www.menti.com, enter the code 299673, and this was presentation number 12. So you can now submit your ratings. The final presentation is from the Department of Surgery, Dr. Hiba Azzeddin.
Hi, thank you. So, basically, I'm the last presentation, so I try to not bore you. I'm sure you all want to continue your work. So I'll be talking, my presentation, first I'm from the general surgery, and this was a collaboration with the gastroenterologist Dr. Yasser Shaib, who was my mentor as well. The title of the presentation is The Impact of Vascular Resection on Early Post-Operative Outcomes of Pancreatic Duodenectomy, and this was a result from a national database, specifically an analysis of the American College of Surgeons National Surgical Quality Improvement Program database. Basically, to start, I should tell you the goal of our research so we can understand what we try to do here. So the study basically examines the early post-operative complications following venous resection as well as combined venous and arterial resection during pancreatic duodenectomy, or what we call the Whipple procedure for pancreatic carcinoma. So a little bit about the background. We know that pancreatic cancer is the fourth leading cause of death among malignancies. We know that We know that the Whipple procedure or pancreatic duodenectomy remains the standard of treatment for these tumors, and we also know from the literature that patients who undergo surgical resection have increased survival in comparison to those who receive only chemotherapy. However, that being said, only 80% of those who present with pancreatitis at the time of presentation are actually resectable, 15 to 20% are unresectable, and those who do undergo curative resection, the 5-year prognosis, the 5-year survival remains at 20%. So who is resectable? And this is where the problem is. Defining resectability is still the subject for debate, and with advances in surgical technique and with chemotherapy nowadays, this brought up the borderline resectable group. And this group of patients is those who have locally advanced disease with vascular involvement, but were not previously considered candidates for resection. So we know previously venous resection or venous involvement or arterial involvement were unresectable. They were contraindications for resection. And however, now the current guidelines have grouped the venous resection, the venous involvement patients under the borderline resectability in the stage 3 group, and those who have arterial are still within the stage 4 unresectable. So what we did is, we took our population from the ACS NetScript database. It's an American College of Surgeons National Surgical Quality Improvement Program across 500 institutions, and ABNC is involved as part of it. And the inclusion criteria were all those who have pancreatic adenocarcinoma who underwent Whipple procedure, which was based on certain CPT codes or R codes in the years of 2014 and 2015. Anyone who had metastatic disease, anyone who had only arterial resection, because there were a very small number of patients, and all other pancreatic biliary malignancies were excluded. So the predictor variables, primary predictor variable was venous resection and venous and arterial resection. Secondary predictable variables were derived from the database entry of the NetScript, which were sex, race, age, diabetes, smoking, COPD, hypertension, transfusions pre-op, ASA classification, and neoadjuvant chemoradiotherapy. Outcome variables, the primary outcome variable was a 30-day mortality after surgery. Secondary outcome variables were also derived from the NetScript, and they included composite morbidity that was broken down into wound infections, cardiac complications, respiratory complications, thromboembolism, sepsis, bleeding, and length of total hospital stay, operation time, and other factors. Statistical analysis, a p-value of less than 0.05 was considered statistically significant, and our data was reported in odds ratio. So the results will be broken down into a descriptive analysis, operative outcomes, and then 2 subgroup analyses. So first, the descriptive statistics showed that first we have 3,519 total patients, of which 650 underwent venous-only resection and 131 underwent venous and arterial resection. And from all the descriptive analysis, the most important to see is that chemoradiotherapy was higher in those who underwent venous-only or any vascular resection, basically. There's a problem with I think the software type, and when it's not complete. But what you should have seen here basically is that what we saw is with venous resection or venous and arterial, so any type of vascular resection showed a significantly longer operation time, however, no increase in the length of total hospital stay. So, okay. Subgroup analysis. The first subgroup analysis is for patients who underwent only venous resection. So we reported it as odds ratio and adjusted odds ratio. Adjusted odds ratio was adjusted for chemoradiotherapy, for age, for smoking, and for stage of tumor. And it showed that mortality was not statistically significant between the two groups. So those who underwent venous-only resection did not have a higher rate of mortality. However, they did have a higher rate of composite morbidity, so morbidity from the surgery. Specifically, respiratory complications, thromboembolism, bleeding, and the 30-day reoperation. The second subgroup analysis was those who underwent venous and arterial resection combined. And that showed weirdly, oddly, that the 30-day mortality was only statistically significant after adjustment for the variables I told you, and in the composite morbidity, the only statistically significant result was bleeding. So those who underwent arterial and venous resection had higher rates of bleeding. Okay, so what's the conclusion? The take-home message is that our results concerning venous resection only suggest a benefit in selected patients, providing the survival benefit over palliative therapy, whereas the impact of arterial resection requires, of course, further clinical trials with higher sample sizes. And these are
So now for the final evaluation over Menti. So if you would like to evaluate this oral presentation, and you access www.menti.com, enter the code 299673, and this is presentation number 13. I would like to remind you that this is the final presentation from the FRRP program. So this is the last time that you will get to vote and put your ratings. So this is presentation number 13. And you can now enter your ratings. So I would like to thank all the graduating residents that presented their oral presentations. On the program, there was a coffee break. However, we will cancel the coffee break due to time restrictions. So now we will move to the MRVP students. So I would like to welcome the co-director of the MRVP program. He is our organic chemistry professor, Dr. Bilal Kafarani.
Good afternoon, after this long day or afternoon. We're going to start the session recognizing some distinguished students who have done outstanding research in the Medical Research Volunteer Program, MRVP. In MRVP, AUB undergraduate students are matched to work on medical research projects with researchers from the AUB Faculty of Medicine on a volunteer basis. The MRVP was founded in May 2014. After a 2-year dormant phase, the MRVP is now under the umbrella of the Clinical Research Institute. Dr. Hani Tamim and myself serve as co-directors of the MRVP. The MRVP has grown so fast in such a short time. In the last 4 years, 444 undergraduate AUB students have worked with 70 researchers from the AUB Faculty of Medicine on 229 projects. And these students come from all faculties at AUB. 18 students have already co-authored 14 publications in prestigious medical journals. You can learn more about the MRVP by visiting the website www.aub.edu.lb/MRVP. The Ibrahim and Lulu Dur Endowed MRVP Awards were established in May 2015. The late Professor Ibrahim Dur was a faculty member at the AUB Faculty of Medicine. As of this year, the two $1,000 cash Ibrahim and Lulu Dur Endowed MRVP Awards are given annually to 2 students, one male and one female, enrolled in MRVP who have demonstrated outstanding medical research capabilities based on the MRVP committee evaluation. It is my distinct pleasure to introduce the speakers of the 2017 Ibrahim and Lulu Dur Endowed MRVP Awards, so last year's winners. The first speaker, Zahra Rahal. Zahra worked with Dr. Humam Qadara, and the title of her talk is Etiology of Non-Small Cell Lung Cancer in Low and Middle Income Countries. Zahra, the floor is yours.
So hi everyone, I'm Zahra Rahal. I'm currently a first-year medical student. During my MRVP project, I had the opportunity to work under the supervision of Dr. Humam Qadara in order to investigate the etiology of non-small cell lung cancer in low and middle income countries, LMIC. Lung cancer is the leading cause of cancer-related death worldwide. Despite recent advances in treatment, the overall prognosis remains dismal. For instance, the 5-year overall survival rate is around 18%. Those low survival rates are mainly due to the late stages of the disease at time of diagnosis. Therefore, we have the need to find new techniques for early detection of lung cancer. And like any disease, in order to be able to detect it earlier, we should have a deep understanding of the pathogenesis of that disease. Thus, we need to understand the early molecular events that lead to the development of lung cancer. Lung cancer is divided into two subtypes: small cell lung cancer and non-small cell lung cancer, which I'll be referring to as NSCLC throughout my talk. As you can see, NSCLC accounts for the majority of diagnosed lung cancer. In addition, NSCLC is causally related to smoking. Since we have more than 500 million smokers worldwide, thus we have more than 500 million individuals at risk for this fatal malignancy. Unfortunately, the growing burden of cancer worldwide is sustained by low-middle income countries, LMIC, where more than 20 million annual cancer diagnoses are projected for 2025 in those countries. In addition, 80% of regions with the highest smoking rates among males are in low and middle income countries. As you can see, apparently there is a technical problem, but this is a figure from our paper. It can show that the Middle East is one of two regions where cigarette consumption has been increasing in the past few decades. Also, Lebanon, the trends of smoking in Lebanon are increasing, and the prevalence of smoking in males in Lebanon are in the range of 50 to 60. Of note, the highest age-adjusted smoking rate in the MENA region was for females in Lebanon. In addition to cigarette smoking, tobacco consumption in the MENA region, specifically in low-middle income countries, are not only cigarette consumption. There are many other variants such as water pipe smoking. And this phenomenon is increasing worldwide, particularly among young adults. This accentuates the need for further study in order to see the effects of water pipe smoking on lung pathophysiology and on lung cancers particularly. Although tobacco consumption remains the primary risk for respiratory diseases, in Lebanon, indeed, air pollution is also a prevalent risk factor, especially after the unprecedented peak of air pollution after the 2015 waste crisis management. All these factors led our group to speculate that the etiology in low-middle income countries for lung cancer is complex than other countries. And this is mainly due to the exposure to different types of carcinogens such as cigarette smoking, water pipe consumption, and also ambient air pollutions. Thus, we have the pressing need to study the complex etiology of non-small cell lung cancer in low-middle income countries. And finally, I'd like to take this opportunity to thank the MRVP committee for granting us this opportunity to be exposed to the research field at the undergraduate level. And thank you.
Thank you, Zahra. The second speaker is Daniel Badin. Both Daniel and Zahra were biology senior students when they were working on their MRVP projects, and both of them are now Med1 students at AUB. Daniel worked with Dr. Lama Sharafuddin, and the title of his talk is Targeted Educational Program Improves Infant Positioning Practice at the NICU. Daniel?
So good evening everyone. My name is Daniel, I'm an advanced student, and this is a project I've worked on under the mentorship of Dr. Lama Sharafuddin for around 3 years in my undergraduate years through the MRVP program. So it's a quality improvement project that aims to improve infant positioning in the neonatal intensive care unit. And the reason we care about this is because infants admitted to the neonatal intensive care unit are often prone to many types of deformities. And for example, positioning has been shown to have a huge effect on this. For example, improper positioning has been shown to promote defects in developmental milestones and asymmetric posture, while proper positioning has been shown to improve sleep, decrease crying episodes, promote midline orientation, but also prevent these defects. So a targeted education program was invented to train nurses and residents to properly position infants. These are some examples of improper positioning as compared to proper positioning. So the Plan to Study Act cycle was adopted as a framework for this project. The plan phase involved identifying the problem, creating an educational package to train nurses and residents, finding an objective measurement tool to measure infant positioning. The do phase mainly involved performing the educational intervention. The study phase involved monitoring the implementation of this intervention and measuring scores pre-intervention, comparing them to post-intervention, measuring the positioning scores, positioning efficacy. And the act phase involved monitoring the progression of the cycle and identifying problems that were faced during the cycle to improve the ongoing cycles. And basically we repeat this over and over again until we get better and better and better scores. So these are some of the problems that were identified to be hindering proper position or promoting improper position. There are many, but they mainly involve, for example, high patient load, low experience and knowledge in positioning, the absence of a proper positioning measurement, and the absence of measuring equipment that can be helpful. So the educational package mainly involves formal PowerPoint presentations, video demonstrations, individual hands-on practice sessions, and refresher courses for new nurses and rotating residents. So some numbers, the results that are going to be published are those of 2014 to 2016. However, the cycles are still ongoing up until now to maintain the scores that were reached and further improve positioning efficacy. Over this period, 52 residents and 39 nurses were attending the educational sessions. 15 educational sessions were performed, and a total of 54 infants were observed 207 times for their positioning. These are the scores. So these are the scores of 2014 to 2016. As you can see, the y-axis is how well the infant is positioned. It ranges from 0 to 12, 0 being the worst position and 12 being the best position. The x-axis is days, so it's basically the time from 2014 to 2016. A goal of 9 was set to be satisfactory. It is internationally accepted as a satisfactory position. Each one of these blue dots is a single position, and the brown thick line is the mean of the positioning scores. So as you can see, we started with 3.6 out of 12, which is relatively low. We improved to 6.3 over 2015 and 7.3 over 2016. And this is the same diagram for 2017 and 2018. As you can see, we improved up to 9.13, achieving the goal that was set. And the cycles, as I said, are ongoing up until now to maintain the score and improve it and train new nurses and residents. So the lessons learned, we learned how complex it is to change behavior. It took almost 4 years and huge efforts from the positioning team, but it was achieved, and it was achieved with very little cost overall. So it was achieved with a huge human efforts with very little financial cost. And I would like to take a moment to thank Dr. Lama Sharafuddin for her amazing mentorship, to thank Mrs. Sadia Masri personally for helping me throughout this, for teaching me everything I need to know. To thank the infant positioning team for their huge efforts in the success of this project, and to thank Dr. Bilal Kafani and Dr. Hani Tamim and the MRVP team for allowing students like me to participate in research.
Thank you. The good news, we're done with presentations. Now it's time for awards. We will start with the MRVP awards. So now we will announce the winners of the 2018 Ibrahim and Lulu Dur Endowed MRVP Awards. I saw Dr. Julnar Usta earlier today. I called Dr. Julnar Usta to the podium. Dr. Usta will be representing the Durf family. I also invite Dr. Samia Khouri and Associate Dean Ammar Olabi, and Dr. Ili Aqil, Dr. Hani Tamim. The first recipient of the 2018 Ibrahim and Lulu Dur Endowed MRVP Award is Miss Lara Sha'ban, majoring in nutrition and dietetics, working with Dr. Ahmed Fawzi Al-Yazbi in the Department of Pharmacology and Toxicology. Yes, exactly. The second recipient of the 2018 Ibrahim and Lulu Dur Endowed MRVP Award is Mr. Bashar Hassan, majoring in biology, working with Dr. Iman Sbaiti in the surgery department. Done.
Thank you very much. What we're doing now, we're doing the calculation for the FRRP awards. So we have few oral presentations or awards for the oral presentations. We have few for the posters. We have the Mentor of the Year, and we have the GRE Coordinator. And I think we are busy calculating the scores. We are taking all the numbers. Yeah, we're done. We're ready. So Pamela will be taking over to announce the names. Again,
now to sign for the FRP awards, I would like to invite Dr. Samia Khouri and Dr. Ili Aqil and Dr. Hani Tamim. While we wait for the oral presentation results, we will start with the poster awards. The first poster award will go to Dr. Farah Mala'ab from the Pediatrics Department. Is Farah in the room? Would someone like to receive the gift on her behalf?
بس تفضلي
Dr. Deep Cecile. Deep Cecile from the Obstetrics and Gynecology Department.
Thank you. Next.
Dr. Vanessa Aid. Vanessa is from the Internal Medicine Department. Dr. Mary Furqui, Family Medicine. Muhammad Ayash, anesthesia.
ايه اوكي هلا ظبطها بس خليها على جنب.
So the oral presentation, the results are out. The third prize goes to Dr. Ali Imrad. Ali Imrad is from the Obstetrics and Gynecology Department. The second prize is for Dr. Sharib al-Matar from the Internal Medicine Department. And the first prize goes to Michelle Sibali from the Diagnostics Radiology Department.
لازم تبقى حدا يعملها سكتين ورا اي فورها
Now the FRRP program would like to appreciate the department coordinator. If it were not for these coordinators, so each department, I'll give you a little bit of background. Each department has a coordinator that we work closely with. These coordinators follow up closely with the residents and make sure that they submit the requirements on time, and they follow up with them regularly. Each year, moving forward, we will submit an award to a coordinator that we feel went above and beyond and worked closely with these residents. This year, we would like to appreciate Ms. Maham Tariq. She is from the Pediatric Department. And finally, this is also the first year that we're going to give an award for Advisor of the Year or Mentor of the Year. This year and moving forward, we asked and we will continue asking the residents to evaluate their advisors or mentors via a line survey. And this year they submitted it. And the advisor who got the most nominations and their comments were really meaningful and it really showed how much they appreciate their advisor was Dr. Usama Abbas from the Dermatology Department.
So thank you very much for surviving the open house today. I would like to thank Dr. Sami Khoury who supported us all along. I would like to also thank Dr. Ali Adel for his directorship and support as well. Finally, I want to thank Pamela who has worked very hard for this open house. Thank you very much, you've done an amazing job. Thank you all for coming and looking forward for CRI staff, of course, like Maha and Olivia and Clara and Asra. Thank you very much. I enjoyed the thanks.